Hi, I'm Suzanne McGurn, President and Chief Executive Officer of the Canadian Agency for Drugs and Technologies in Health, often referred to as simply CADTH. It is my privilege and honor to moderate today's webinar, which is the second in a series of webinars on remote monitoring for cardiac conditions. As we get today underway, I'd like to start with our territorial acknowledgement. CADTH recognizes the inherent and treaty rights of all First Nations, Inuit, and Métis people across this land. We acknowledge the harms and mistakes of the past and are committed to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. CADTH staff work across Canada, living on various traditional lands and collaborating with Indigenous governments, healthcare providers, and community members. Our Ottawa offices are located on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. Our Toronto offices are located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat. Wherever you are listening into this webinar from today, I encourage you to think about where you live and work and give thanks and recognition to the Indigenous people who lived there before you and who live there still and continue to sustain and protect the land you call home. As we get into the session today, I've just reminded that as noted in the first webinar, if you participated, the expansion of digital health since the start of the pandemic has been remarkable. And the remote monitoring for cardiac conditions is no exception. While we reviewed CADTH's evidence and heard clinician and patient perspectives in our first webinar, today we'll explore policy and implementation side of things and hear from our panelists. I'd like to introduce them to you now. First off is Aaron Naor. He is a policy and program analyst here at CADTH. He brings a wealth of experience in policy development. Next up is Cindy Fajardo, who is the lead for clinical design and informatics at the remote care management programs with Ontario Health, Population Health, and Value-Based Health Systems portfolio. Dr. Roopinder Sandhu is a cardiac electrophysiologist and an associate professor and director at the Smidt Heart Institute at Cedars-Sinai Medical Center, in addition to being an associate adjunct professor of medicine at the University of Alberta. And Dan Bond is a senior business relationship manager at Eastern Health, with over 20 years experience leading system transformation initiatives, including overseeing the development and implementation of a remote patient monitoring program for Eastern Health. I'd like to thank Dan for stepping in on short notice after Kim Gani from Eastern Health was unable to join us today. And certainly last but not least, I'd like to introduce Arlene Singh, who is the Senior Clinical Leader for Remote Patient Monitoring, Office of Virtual Health, Provincial Health Services Authority, British Columbia. Welcome to you all, and thank you for joining us today. About the format, we're going to go through a number of structured questions with the panel about implementing remote cardiac monitoring programs to get things started. And later, I'll open it up for questions from the audience. You'll see on the slide how you can do that using the Q&A button in the Zoom control panel. If your ask is for all of the panelists, please indicate so, or if it is speaker specific, please also note that, and I'll do my best to direct that questions appropriately. So with that, I think we're ready to get into the questions. So maybe to give everyone a chance to weigh in, as I started off, cardiac monitoring and virtual care really expanded during COVID, but that's not the case for everyone. Work was also being done beforehand. So perhaps if we could start off with, what has been your experience with remote monitoring, both prior to and during the pandemic? And I'm going to kick this off with you, Dan. So over to you.
Thank you very much, and glad to participate today. We had at Eastern Health, we're the largest health authority on the island of Newfoundland and Labrador, the Avalon area, St. John's in particular, about 300,000 patients. About 8 years ago, we had implemented a remote patient monitoring program, and we started with COPD and heart failure. It had been very successful, and I guess when the COVID pandemic started to ramp up, we were able to take our lessons learned from those initial clinical protocols that we developed and quickly expanded for us. COVID-19. So it was something we were able to do very quickly based on already having an existing RPM program.
Got to get my mute button correct before we get it too far into this. Over to you, Cindy.
Hi, so I'm from Ontario Health, and for us, there were really two main factors that we believe was fundamentally impacted by the pandemic in terms of the implementation of remote care management programs. The first one was the breadth of patient populations with access to remote care program. The second one is the reach of the remote care management program across the whole province. So really, which is a direct result of sort of the opening of the doors for increased engagement. To give you a little bit of context, so prior to the pandemic, our organization worked closely with about 10 organizations across 8 regions in Ontario. We work with them to facilitate, implement, and support sustainability and scale and spread of a heart failure and COPD self-management remote care program. And all were established by 2014, some as early as 2012. And they were very successful programs, but they were limited to these programs and patient populations. And there were a couple of regions that we didn't really have the reach to be able to start a program. Contrast that to post-pandemic. So even within a couple of months of pandemic, as early as April 2020, so many of the barriers to engaging and implementing that we previously saw pre-pandemic, whereas for almost a decade, it was us reaching out to folks to really consider remote care as another complement to their healthcare services. It kind of turned around where it was sites were seeking us out to partner with us and say, hey, you've made this work, help us out. And by the end of 2020, we were really able to grow the remote care program supported by Ontario Health OTN from a couple of pathways for heart failure to and COPD programs to provide remote management for with individuals positive or probable for COVID infections, for frail elderly to meet like ALC wait time increases during the pandemic, for support post-surgical to again meet the surgical wait times increases. And by 2021, we were able to establish a process to provide startup funding and sustainability for the remote care programs. And we went sort of from 10 organizations to 8 regions to supporting over 75 organizations across all of the regions. And just to summarize in terms of numbers, so from 2012 to 2019 pre-pandemic, we had enrolled about over 19,000 patients with heart failure and COPD. And then just last year, compare that to last year, just 2021, we were able to have 10,000 patient enrollments in just 1 year. So that's a little bit about us.
Thanks, Cindy. So we've gotten the east, sort of middle, and we're going to skip over to the west coast. Arlene, what's been happening in BC?
Thank you, Suzanne. So for BC, remote health monitoring isn't necessarily a new concept. It started in 2011 through a partnership with the government, so through something called a strategic initiative fund. So we had a lot of pockets of remote monitoring being done across our various regional health authorities. Primarily, they were focused around chronic disease management. What we did see, though, is during COVID, we saw like exponential growth of remote patient monitoring now being used to support patients who were either exposed to somebody who had COVID or either confirmed positive cases. So these were being used for like case and contact, monitoring of patients. And so since then, what we have seen is great growth in terms of more chronic disease programs, as well as onboarding to new specialty areas. So we have areas like chronic kidney disease, we have BC Cancer, we have BC Emergency Health Services that have onboarded to use remote patient monitoring. So I think really what ended up happening with the pandemic is that it really sort of pushed people to see that it's no longer a nice to have. It is now something that we need as an essential to be able to support safe patient care spaces. And so I think that really worked to help support the advancement of remote patient monitoring throughout the province.
Thanks, Arlene. And Rupi, over to you from a clinician and academic perspective.
Thanks, Suzanne. So similar to Arlene, remote monitoring hasn't really been a new concept. It's been used for a variety of chronic cardiac conditions, and more in terms of a method for consultation of patients in remote areas. But during the pandemic, virtual care really became the most commonly used mechanism of contact with patients, regardless of their location. And that the major change really happened with how consultations were occurring. So there were more non-face-to-face methods. So a lot more phone calls that were occurring than anything based on a virtual platform where you could necessarily see the patients. And I think even now, people are getting used to COVID as part of daily life. But there's still a considerable number of patients that are reluctant to come to inpatient visits. And I think knowing this, remote monitoring programs really give us an opportunity to change the face of healthcare delivery. And I think is an important thing that we really need to pursue.
Thank you for that. And that's a perfect segue into the second question, which, you've all done a great job of talking to us about the moment in time that a pandemic has to allow us to overcome barriers that we didn't think were possible just 2 or 3 years ago. But as you said, there are still challenges for remote programs. And how have you been able to identify those, and how have you been able to overcome them? And I think this time we're going to start off with Aaron, who's going to give a bit of an overview from the work that's been done here at CADTH about some of the barriers to the remote monitoring. So over to you first this time.
Yeah, thanks, Suzanne, and also a pleasure to be here. And unlike the other panelists, while I haven't been involved directly in a remote monitoring program, I have been working here at CADTH with the team to develop our policy review, which is called Enablers for Remote Monitoring Programs for Cardiac Conditions. And it really looks at the enablers and barriers that remote monitoring programs faced here in Canada and the lessons that we learned throughout the past couple of years during the pandemic. And I think from a policy perspective, there are really 2 areas where there have been challenges. First, in terms of clinician reimbursement. So here we're talking about how do we incentivize the use of remote monitoring services when it's appropriate to ensure that we can bring these programs to scale and make sure that clinicians are being remunerated properly, but also in terms of licensure. Remote monitoring, like other virtual care services, offers us an opportunity to expand where we can provide services to patients and have greater access to patients. But this has been complicated by sort of the rules and the laws around interprovincial and interjurisdictional licensure for physicians, but also other healthcare professionals as well. And so removing some of that complexity may help us forge a path forward for remote monitoring to be more easily accessed across the country.
Thanks, Aaron. And I think as we go around the fireside chat this time, please feel free to build on any of the ideas that Aaron identified in the research that's been done here at CADTH, or to share the experiences you've had locally about how to overcome those barriers. And this time I'm going to start with you, Rupi.
Well, I think remote monitoring programs definitely present some really valuable opportunities. So it gives us an ability to identify and intervene earlier to potentially reduce acute care visits and really empower patients to be more involved in their care. But there are some challenges that need to be recognized, I think, across all the major stakeholders, and particularly from the provider perspective. Some of the things that we think about is the potential for increased workload. So the number of contacts that we're having with patients, the increased amount of data to review, increased administrative tasks, the need to make rapid decisions based on responding to alerts that may interrupt your workflow. Some of that may be obviated by having perhaps more support staff, maybe balancing expectations around volume as possible mitigating solutions. And then I think one of the other major challenges is the integration of remote monitoring into the electronic medical health record, and the ability for providers, all providers in terms of the patient care team, to know what's really been going on and to make decisions appropriately based on that information. And of course, with the increased workload, we do always think about remuneration and how does this increased workload for the whole patient care team relate to appropriate compensation. So just a few things to consider from a provider perspective.
Thanks for that. And I see lots of nodding heads. So next over to you, Cindy.
And I think to build on that, I think you spoke with the provider perspective, but then also I'm going to look at sort of jurisdiction perspective. After the rapid growth with the pandemic, now the next challenge now is how do you make it stick, right? So how do we make it sure it's sustainable? And I agree with in terms of integration, in terms of the digital solutions, but also really a true integration of remote care as a permanent part of a larger strategy to support individuals with cardiac conditions. I think one of the challenges, of the continued challenges, is the need to really align remote care in the roster of services and making it seamless and well-informed. So I think there's sort of the provider level where there is the sort of how do you manage the increased workload. And on the other end, sometimes, programs will create a program, but they haven't sort of really engage and ensure upstream circle of care awareness and engagement to make sure that people that will be referring, depending on where the patients are coming from, are aware of the program and are bought in. So I think in terms of that piece, there's really one of the facilitators is to make sure to involve key stakeholders like a physician champion at the beginning of your planning, engage with your peers and answer specific questions, but also those that will be providing the care, really involving them because they will be most aware of the day-to-day processes and of the potential challenges and suggest the creative solutions. So those are some of the we looked at sort of what the two main challenges are with the implementations, and one of them is around sort of referral processes and stakeholder involvement.
Thanks, Cindy. Dan, you're next. And when you're done, Arlene, if you want to follow, that would be great.
Yeah, I'd agree with everything that's been said so far. So looking back, if I go back 8 years ago, really we were focused on awareness and sustainment. So, awareness coming down to change management, where RPM for us at the time was a new concept. So how do you educate all the providers and the various stakeholders that RPM is a technology that they would be interested in and would like to invest their time in learning more about? And then more importantly, making sure that those physicians and champions were comfortable referring their patients into this program, because it was net new at the time. So it's a little bit of a leap of faith that we're going to ask someone to historically had seen the patient in person to now refer them into a virtual session. So a lot of change management. And then the second question, or the second part to that, was really the sustainment of it. So it's one thing to start the RPM program, but how do you ensure it's successful long term? And one of the things that we've done as an organization is we've developed an RPM program that is very much standalone, but to the other panelists' points, we're trying to integrate it as close as possible so that folks are aware of it. But we have dedicated staff, particularly RNs, that are dedicated to maintaining and supporting the RPM solution.
Yeah, and I definitely agree with everything that's been said already. One of the things I wanted to highlight is that, we know that with remote patient monitoring solutions, there is, significant impact and benefit to the patients that we're serving, as well as in terms of the organization. We see more system efficiencies, better processes. But the challenge is that in order to implement a remote patient monitoring solution, there is a lot of upfront time, resources that need to be invested into it. And I think that is one of the biggest challenges when we have a healthcare system that's overburdened overwhelmed and we have so many competing priorities. So I think for us as an organization at PHSA, how we've approached this and tried to sort of mitigate that is that we have dedicated virtual health team. And so what we do is we provide that project support, that clinical leadership. We work with them. We have members of our team who are experts in practice, in education, in evaluation, in data and analytics. And so we really, really work with those teams and those programs and services to show them the value that an RPM solution would have. We sort of align ourselves with the change champions within those areas and really see that project through and make sure that we have a really good evaluation to show what that impact and that outcome of that will be. Another thing that we've found to be really successful as a province as a whole is that we've had quite good provincial collaboration amongst all of the regional health authorities to really bring forward like standardization. I think along with the COVID pandemic and introduction of new virtual care platforms and solutions, we have provincially come together to share lessons learned, ideas of how to move forward collectively as a province. And I think there's a lot of value in that, to be able to learn from each other, to be able to, rapidly iterate and adapt and continue to improve how we support our programs and services.
Thanks, Arlene, and thanks to everyone on the panel. I mean, your answers collectively talk about, the value of the efficiency, especially when we have a health human resource challenge, but also how do you care for the health human resources during transition and as we move forward, and also reflect on sort of that human touch piece that we heard about last week at last webinar with our patient representative as well. So maybe just in light of what you've identified as opportunities for overcoming barriers, I think underlying some of your responses are actually a number of legislative or regulatory policy changes that could be enablers and could help scale up or maintain and sustain what we've been able to do successfully. I guess I should correct that and say what you've been able to do successfully during COVID. Perhaps if we could just go around the table again and talk a little bit about any policy levers that could be enabled to continue the success of remote monitoring. Maybe I'll start with you, Aaron, as you kicked us off the last time on what did you find when you were looking into this from an evidence perspective?
Sure, yeah. So, I mean, earlier I mentioned reimbursement as a key consideration for policymakers. And this is something that the provinces and territories were actually very attentive to at the onset of the pandemic. Most provinces and territories were fairly rapidly able to introduce virtual billing codes, which have largely been seen as an enabler for virtual care services. And most were put into place in March, April 2020, but they were announced as temporary. And so with the exception of Alberta, which has made these codes permanent, it's generally not clear how remote monitoring services will be reimbursed in the future. And it's also not clear how applicable that the virtual billing codes that we have are for remote monitoring, especially considering that often different elements of a remote monitoring service may be offered by different healthcare professionals and at different times. And so some have called for specific billing codes for remote monitoring, and that's really been seen as a way to incentivize the use of these types of services. Others have more broadly been discussing whether other payment models beyond just billing codes should be considered. Either way, governments should really be looking at how to signal reimbursement for remote monitoring services on a more permanent basis, because I think that would really help programs be able to develop longer term plans and make sure that they can be done so in a feasible way.
Thanks, Aaron. Dan, maybe from an Eastern perspective or Canadian perspective, what would your feedback be on this topic?
Well, I don't even know if it's even specific to remote patient monitoring, but just the technology in healthcare in general and how it drives change, particularly fast change. And sometimes legislation doesn't keep up with the pace of that change. So to Aaron's point, we certainly did have temporary codes for COVID. But if I look back to just remote patient monitoring in general, telehealth was historically done where the patient went to an institution. So a telehealth visit involved me going to a hospital and then having my consult. Remote patient monitoring really takes that a step further. I no longer need to travel into an institution to be seen. I'm going to be seen from the home. So now you're going to have an appointment that's home-based, and necessarily the legislation hasn't been updated to reflect those home-based visits. So I think that's one of the things going forward that we need to ensure, I guess, what's defined as a healthcare visit, and that we really do need to see the patients wherever they're located.
Thanks, Dan. Over to you, Arlene.
Yeah, I definitely agree with everything that has been said. I think from an organizational perspective, it also requires looking at some of our policies as it relates to virtual care, the ability to do secure text messaging and what is appropriate, what is not appropriate to be communicated via telecommunications with patients, as well ensuring that we work with our programs and services to design clinical practice guidelines and look at revamping some of those things that have existed already, but maybe are not aligning with best practices for, virtual and remote care. And so I would say really taking a look from a clinical practice perspective is really important, as well as within the organization. What are our policies? Working with our security and privacy teams to really reevaluate some of those things to make sure that they align with modern day initiatives.
Cindy, anything that's been missed that you'd like to add to this one?
I think part of the policy levers, I think, is funding. So I think one of the things that we've done here in Ontario during the pandemic and continuing this year is committing to, the Ministry of Health has committed to and created a process to provide funding support for Ontario health teams and other eligible healthcare provider organizations to be able to sustain and scale the program. So the proposals are really accepted from those who are interested, who wish to create new remote care management programs, as well as those with existing remote care management programs that were previously provided funding, but has demonstrated implementation and outcome success. So really to focus on some funding to continue to support the scale and spread of those successful care models and then promoting them to others as well. So I think that's sort of in the shorter term, but in the longer term, really moving towards a population-based sort of healthcare delivery systems, looking at, focusing on the patient's full sort of experience of care and value-based care, and making sure that, with our focus on avoiding acute care utilization, is that, that the innovative use of technology, data, and other kind of initiatives to transform healthcare delivery is supported, has the infrastructure, and provided some funding.
Thanks, Cindy. For any of our participants who may not be from Canada, just to flag that in many of our jurisdictions, billing codes, et cetera, do sit in regulations, and so do need to be updated through a regulatory process. And obviously, privacy legislation and the sharing of information, as well as the way that health providers are regulated, is within our provinces and territories. And as was highlighted earlier, that need and ability to be able to transition from jurisdiction to jurisdiction. So, we've gone through some very specific questions, and there's obviously a lot to consider in terms of designing and implementing a remote monitoring program. For those who are listening in that haven't done so yet, and have been listening to this conversation, what would be your best advice to them on how we can ensure to continue to implement remote monitoring programs in a successful and sustainable way? So maybe, the one or two things that you think have made the biggest difference to the success of the programs you're involved in, or if you got to go back and do it over again, what might you have done a little bit differently to start faster and move this important technology forward? This is sort of open to everyone. So it's very hard to do that on a Zoom. So I'm maybe going to just do the same thing and sort of go around the table, and please feel free to pass if you don't want to chime in. So Roopinder, maybe over to you first.
Sure, thanks for that question. I mean, for me, putting my researcher hat on, I think one of the biggest components for future success and sustainability is to have an appropriate evaluation component to your remote remote monitoring program. So what are you and this is something that's decided with all the stakeholders. So it's not just from a clinician perspective, but from the hospital administrators to the patients that are involved. What are the appropriate metrics that would define success of a program? And I think being able to relay that those goals to each of the stakeholders would be important as well, and the ability to track costs as part of that evaluation component.
Yeah.
Thank you.
I'll jump onto that about cost, because I think that's an important piece of the puzzle that in many cases is still missing, and that's understanding the costs and the cost effectiveness of these technologies and programs. There's still a lot of uncertainty with regards to the cost effectiveness of remote monitoring programs. There, from our review, there were a small number of studies that pointed out to a very wide estimate of costs. So there's more work that really needs to be done to understand costs, during setup, during the operational phases, but also the cost effectiveness across different conditions and within certain populations. There's a lot of credence that's given to the benefits of remote monitoring programs in rural and remote populations, but this was found to be a significant evidence gap. So rural populations, racialized groups, Indigenous populations, there's a lot of evidence gaps that still need to be filled, I think, to understand what circumstances we can best get the value out of remote monitoring.
Thanks, Erin. Arlene?
Thanks, Suzanne. I mean, it's definitely hard to narrow it down to a few different things, but I think first and foremost, I think there really needs to be a push from leadership, and there needs to be a strong sort of clinical strategy in how we implement remote patient monitoring into programs and services. So I think that really helps support not only the implementation, but also the sustainment of those programs. And then next, I would place a lot of importance in the designing of the remote patient monitoring program. I think there needs to be a lot of investment in terms of time into looking at what are we actually trying to achieve with remote care monitoring. We're introducing a new model of care. And so is there a gap in a service? Are we trying to reduce the number of visits? Like really trying to tease out what it is that we're trying to do. How are we going to achieve that? And so this, I believe, needs to be a really strong partnership with those clinicians that are actually on the front lines delivering the service to really understand what is that problem. And then I think, Rupi mentioned this before, is like that integration. We know that when and I can speak for BC in the virtual health projects that we've implemented, usually we don't start with an integrated solution off the bat. These are often an add-on solution, which is actually just an added, I wouldn't say a burden, but added step to a clinician's workflow on top of documenting within their EMR, delivering that patient care. And so really, I think off the bat, if we work at designing an RPM program and working it into that clinician's workflow and having integrated solutions that are seamlessly integrated into, let's say, their calendar booking system, their electronic medical record, their electronic health record, that really, really helps to make sure that we're being very efficient and that we're not, increasing that burden on the providers. And that definitely helps with like sustainment and making sure that the initiative continues on and is being implemented on an ongoing basis.
Thanks, Arlene. I'm going to go to Cindy and Dan, and maybe just with a reflection on something you said, Arlene, which is about giving it the time and space. And I think, for me, as I'm listening to everyone talk and realizing we've just been through a pandemic where people didn't really have time and space. And now, as we are getting to a new place of COVID, people are tired. And so maybe if I could go to Dan first and then Cindy and just say, how do you find that right balance of moving forward so that, we don't get stuck where we were before? And I think, Dan, you described it as the 10 years leading up to COVID, so that we can keep up momentum, but do it in a way still that responds to all of the success factors. So over to you, Dan.
It is following up on some of the other things that were said around the integration being key, and think one of the things we started without integration because it wasn't a requirement, where it was kind of a proof of concept, and we have moved to integration, but we didn't start with digital integration. We started with the traditional mail out of reports, and one of the things that we did, so we didn't, I guess, overwhelm folks, was we don't send daily reports of how the patients are doing. We met with our stakeholders, and they said that monthly would be the way to go. So I mean, that worked for us. So I would say that when you're designing your program, look at who you're trying to reach for your target audience, and then kind of work with them to pick the dates and the timeframes that work for them in terms of the engagement and how much information that they want to see. They may only want to see a summary of a flow sheet. They may not necessarily want to see every single measurement that's come into an RPM solution. It just may be too much information.
Cindy, anything to add?
Yeah, and I think just to sort of build on and reiterate the importance of designing your remote care programs, I completely agree about the integration. It needs to be part of your long-term sort of strategy for supporting these populations. And when you're designing because from our experience, we're doing a lot of proposal funding and evaluation of those programs. And time again, what we're seeing is that there's not enough emphasis on really making this a distinct part of your sort of long-term plans for care. And for a remote care program to thrive, it really needs to be considered a valuable component of that, acknowledging that it is a unique role. One of the pitfalls is around, and Arlene had brought this up, is around dedicated staff. And we have seen time and again that groups that believe that they can make it work without dedicated staffing, most times the program fails. The groups that we have seen succeed had assigned dedicated staff, and that's really necessary to be able to sort of develop the commitment and investment to the success of the program, to develop that community of practice, a body of knowledge in which they can build on and improve from, and to be able to sustain it long enough to be able to test and measure outcomes that will be talked about. So if we don't measure outcomes, we don't know how we can what the real value of it is and how we can improve. And I think that the groups that we have seen that really commits to a dedicated place and a role in staffing for remote care programs are really set to be successful and be able to sustain their programs.
Thanks, Cindy. Just a reminder to the audience, after this next question, I'm going to be picking up any questions. So please feel free to use the Q&A button at the bottom. I see there's a couple as well in the chat, so I'll circle back to those after this next question. And the next question, is very top of mind, I think, for everyone in healthcare. And I know here at CADTH, it's something we're increasingly turning our attention to, which is the topic of equity, diversity, inclusion. And so, Erin, you started off the last comment on sort of where to look in the future. You touched on briefly equity issues. And so, as a key takeaway from our work was that we should avoid exacerbating inequities in healthcare. Were there any solutions in the research that you did? How can decision makers ensure that digital equity remains at the forefront of program planning and implementation? And then I'll quickly do a check-in with folks to see how they're addressing it in the programs they're running.
Yeah, well, CADTH's review really focused on digital equity, digital divide for remote monitoring programs. So in other words, the social inequity among those who have access to these types of digital technologies and those who do not. And there were a number of patient populations in Canada that were described as being disadvantaged when it comes to being able to access remote monitoring programs. For example, patients of low socioeconomic status, older adults, some Indigenous communities. And the reasons behind this can vary. It can be due to a lack of access to technology or to reliable internet. There are many communities in Canada still in both rural and urban settings where access to good quality internet, which is needed for a remote monitoring program, is still an issue. And there were some ways that programs have been able to overcome this. There was one patient we spoke to that didn't have internet, but her program was able to offer her a cardiac monitor that hooked up to her landline. So internet is one issue. Affordability was another big issue that came up. Not everyone can afford an iPhone or an iPad. And so the bring your own device model doesn't necessarily work for everyone. despite the cost savings for the program. And others may also have limited digital literacy or health literacy. Some may have cognitive or auditory or visual impairments. That's an issue we found among some older adults. So some programs were able to modify in certain ways by doing things like having enhanced font size or including both a visual and an auditory component in the interface of the platform. So there are some creative ways that programs have been able to adapt that really help certain patients use these technologies effectively.
Thanks, Aaron. And Rupi, obviously in clinical practice, you run into this practically all the time. Any thoughts that you add to the conversation on equity?
I think one of the opportunities in terms of minimizing potential disparities is even having as part of your team, when you're thinking about implementation, is a health diversity expert. Because there are lots of aspects of healthcare that we may not think about, on an everyday in terms of the way that we conduct our activities. But I think having that expertise may really enlighten us in terms of other things that we should be thinking about to minimize disparities. And I think also in terms of the evaluation component, always reassessing these really important, potentially vulnerable patient populations to make sure how are we addressing their needs and making it an adaptive and iterative process. So we're reevaluating and we're making changes accordingly.
And Dan, how did this look on the East Coast? You've got a very spread out population with only a couple of urban areas.
Yeah, exactly. So one of the things we tried to do to help minimize some of these things was we provide the equipment. So in our particular case, we're providing an iPad and we're providing all the biometric devices. And we also provide cellular internet service as well, if it's available. In some of the rural places, obviously that's a challenge. But one of the benefits to that is that it streamlines your support process. So from an RPM program perspective, you now have control over the technology. So you're spending more time focusing on clinical issues versus IT troubleshooting. I guess the added benefit to that is that you can quickly deploy it to very rural areas. And if what we have found is that if you are in an area where you don't have a cellular connection, but you have your own home internet, a lot of people will use that. And if you don't have that, then if there's a community facility, people that are engaged in the service will actually go to a community center to complete some of their sessions. So we generally don't find access to technology in terms of getting the biometric information being a roadblock. And I guess one of the things we've done is try to put the devices in people's hands to take that away.
Thanks, Dan. Cindy, in Ontario, big geography, lots of Indigenous communities in Northern Ontario as well, many fly in. How has Ontario tackled this?
Yeah, and I think I'm going to talk to sort of what Aaron and Rupi talked about in terms of planning for it, and then a little bit about the implementation that Dan has referred to. So I think part of what we really had to do is to really put equity at the forefront and really challenge the different regions. Like I said, it's very diverse, very urban and very rural and remote, and challenge our, the regions we're partnering with to really identify what are the capacities in your area. So what are the available, where are the cellular sort of, empty spots, and what does that look like? And then when you're planning your remote care program, to already look at, provide a diverse option, because I think we can all agree and be realistic that not everyone is going to have the sort of the same digital capacity, whether it's they don't have cellular connectivity, especially in those First Nations, or even that, it's really remote. So the delivery of a particular device is sort of prohibited in those areas. So I guess our strategy has been, think of, really understand who the population is, and really come up with the different strategies already. So including a provision of managed kits with biometric devices and having a way to deliver that and do inventory and all of those pieces. And also being able to say, what do you need for your program? Do you need it with biometric devices or without? Which areas, or are there areas in your region that can take advantage of bring your own device? And Aaron has talked to some of those sort of components. Also, there's also for areas where there's only landlines, is there like an IVR component, so interactive voice, so that you were able to sort of implement to still have that piece. And one of the things that we've also taken advantage of is sort of a clinician direct entry. So in areas where there's only a phone, we still sort of put a more rigor and remote care component. So for example, they would receive a call from the clinician who would then go through the standardized health assessments that others would just interact with directly from the system, and then have them document that into the remote care system. So they still have access to the trending, the risk stratification, the prioritization, and the documentation. I think it's really looking at who are you serving and what are the different ways that you can sort of impact that. And just one more thing, what Aaron was talking about, what about cognitive impairment? What we've done too is allow programs to partner with informal caregivers, sometimes in the home and sometimes not in the home, to be able to provide that information as well.
Thanks, Cindy. Arlene, I'm not going to go to you this time. I'm going to try and get a couple of the questions from the audience in, and to be efficient with it, I'm going to try and combine a couple. So there's been a couple of questions actually asked about the health human resources or the types of staffing. So two questions that I'll pose is, is there an ideal configuration for staffing the virtual healthcare team? And what kinds of disciplines or others would be ideal or to be thinking about? And along with that, there's a question about sort of where will this go in the future? Will this be linked up to community paramedics, for example, at full maturity? So maybe Arlene, if it's okay, I'll go to you first and then see who else might want to weigh in on this. Really, who does this and how do you think about it going forward?
Yeah, I mean, those are great questions that have come in. In terms of, I would say, like the staffing models, really, I think at the core of it, we really have to look at it from a patient-centered approach. Like, who is that patient population that we are trying to serve? And then with that, you can sort of determine who are those key players, clinicians and providers that are, involved in delivering that patient's care. And so what we have seen in terms of the way remote patient monitoring has been set up is, there is a centralized service model where, it's set up with clinicians or providers that are doing the actual monitoring, but they are not the ones that are responsible for the escalation. So if there's any alerts or any red flags that come in, then that gets escalated to that patient's primary care provider, their specialist, who is then responsible for conducting that follow-up. And so that's one method of, setting up an RPM program. And then the other way could be, we're very specialized clinics. So I'll just provide an example, like cardiac care or even BC Cancer. It's delivered by a specialty group that is with that patient throughout their care journey. And so they're there very intensively monitoring them, providing them that support throughout their treatment or throughout their care journey. And so, there's no right answer to which way is better. It really depends on what you're designing it for and what your ultimate goal is. And again, as far as the appropriate disciplines, I think that's also a very challenging question to answer because there is no right discipline. There is a monitoring clinician that is selected, and that is that person that is going to be reviewing and monitoring the data. What we also have seen is connection to, other supporting services. So for example, you could be providing remote care monitoring for cardiac condition, but the patient may need, psychosocial support. They may need perhaps to be linked into a social worker or even a dietitian. So I think really getting to the core of who you're designing for and understanding what are their needs holistically, that'll really help you, design the programs.
Rupi, I'm going to ask this question to you. It's building on the question about sort of the ideal team and sort of who else should be involved. We have the questions about paramedics, and there's also one about the engagement of family physicians or these types of programs being led through family physicians' office. Any thoughts or comments?
Yeah, I think that's a great question. And what it's really getting to is involving the whole patient care team. So thinking about anybody who interacts with that patient and involving them. And that ranges from EMS to all of the healthcare providers, whether it's physicians, primary care physicians, or specialists, to the nurses, to even potentially pharmacist involvement. So any of the patient care team should be involved. And then thinking about the hospital administration as a key stakeholder voice, and most definitely the patient should be involved. So when I kind of think about how to approach that from a care team perspective, I think anybody that's involved should be included.
Thanks a lot, Rupi. And there are a couple of questions that are specific to patients. And first, I would want to say, if people did not participate or hear the last webinar, it is available and certainly can be referenced. We did have a patient participant as well. And the conversation was about sort of how patient voices were brought into the design of programs. But there's a really, I'm going to say, pointed question that's been included. And Dan, I'm going to come to you with the question based on it. And the question is, who are we building the system for? I've spent days looking for a phone that my mother-in-law can use that does not, that just makes a call on, nothing smart. She will not deal with AI. And I think the comment highlights that there are some people that this doesn't work for. And perhaps with the experience you've had, we talk about sort of this presentation from almost everyone feeling like they'll be successful, and maybe any observations about those that aren't.
Yeah, I'd agree. We generally haven't found resistance to using the technology. There are cases, but one of the things that we've done with our program is we do engage patient advisors, and we do survey the patients, and it's optional as well. So this is by no means the only solution. And if they say would prefer not to use a biometric device, we certainly do have programs and scripts where we would phone the patient. So I'd agree to that comment that you're designing the program for the patient, not for the provider, and that always needs to be at the focus for it. And you really can scale the technology for whatever the use case may be. So I wouldn't see any limitations in terms of a registered nurse using it versus a nurse practitioner. We don't use paramedicine, but I'd seen the comments around that. There are programs in Canada that are administered through the paramedicine program. So the discipline shouldn't be an issue either, would be my thoughts on it.
Thanks, Dan. Cindy, is there anything you'd want to add to that response?
I think it's just a reminder that remote care is meant to be a complement to your usual care. It's not sort of mutually exclusive. So I completely agree. It's really around patient preference. It depends on what their experience is. And the other thing we found too is that it's not just about patient capacity to use or prefer this. Sometimes it's also the ability of the monitoring team, whoever is approaching the patients to get their consent to enroll, of how well they can describe the system. Because if they themselves are apprehensive about the technology, that would translate in how they're conversing. So I think that's another piece. It takes some time to really get your folks comfortable, and then to be able to be comfortably, invite patients to get involved.
I have had more mute button issues than usual today. So we're now at the point where I'd kind of like to do a roundtable, but there's a question in the chat box that I think I'm going to preface your opportunity to make your closing comments with. And I just would, I would flag that, this goes back to the conversation about equity, et cetera. And remote monitoring programs are framed as the solution to provide care to patients in their homes, their own communities, and increase access to high quality services. Unfortunately, there is limited peer review, high quality evidence about the effectiveness of many programs. The evidence gap in evidence is particularly stark for rural and remote, racialized and Indigenous communities, and those of low socioeconomic status. So, Erin, I think, raising some of the questions you've raised earlier. Perhaps as we go around the table, and Aaron, I'll let you respond to the question, people could share sort of what is their evidence or evaluation of how do you know that your program is being successful as part of your closing remarks. So just a minute for everyone on this one. So Aaron, I'll get you to start first and then go to you, Cindy.
Yeah, well, I think that's a great point. I'll go back to what Cindy had just said, that really what we know is remote monitoring is considered a good adjunct and as a complement to other health care services. But like the question said, there are still significant evidence gaps. Earlier, I talked a little bit about the cost effectiveness, but we also need to understand a bit more about the clinical appropriateness, under what cardiac conditions, as I said earlier, which patient populations, what risk severity should we be offering remote monitoring, and also the cost effectiveness around that. Because while there are potential significant savings, there are also costs that we need to account for. And that could be assessed both at the healthcare system provider level, but also at the patient level as well. And so there's a lot more work that needs to be done, both from a cost effectiveness and a clinical effectiveness perspective.
Thanks. Cindy?
Yeah, I second that as well. I think there's some performance metrics that's going to be universal regardless of the program. And then there's some that's going to be specific to that particular program. So I completely agree. Make sure your eligibility criteria is really crisp. What is the goal? What is the care? Who will that care for? It sometimes also will be at the level of the right intensity level, right? So somebody who's just had an acute exacerbation and you're providing post-acute remote care, as opposed to if you're providing self-management. So I think that really needs to be, and depending on those programs, you develop those metrics to measure. It's very important that the metrics you measure can be standardized so others that's doing the same work. I think, just with any evaluation, the more people that you can do it, the larger sample sizes, the more you can prove the value. And then I think the other piece is always have a patient experience component. So important to build that in. What is the patient's perspective? Use validated tools as much as you can. So again, so that it can be something you can compare across programs.
So we've got about 25 seconds for the three of you remaining. So Arlene, last comment.
I'll try to be quick about this, but yeah, I definitely think like with remote care, there is a bit of a gap where we don't see that, end impact of it. Oftentimes it takes longer to materialize. And sometimes, let's say for cardiac condition, you're doing a remote patient monitoring service, you may not see it, but in the end, long-term, it could be helping to prevent some of those high cost events like stroke or heart attack, but really we're not there yet and we don't have that data. This is all just sort of conceptual for us. How we are measuring effectiveness right now is through patient satisfaction, quality of life. We're looking at the data that's coming in, so we're better able to make data-driven decisions regarding patient care.
Thanks, Arlene. Dan?
Yeah, I'd agree with everything that was said so far, and would probably just add that it would be very difficult to sell an RPM program on the basis of reducing costs and taking money out of the system, because that's generally not how it works. So things around the quality of life and access to care, I think those are the things that you want to do your evaluation on.
Thanks, Dan. And last comment, Rupi, over to you.
Well, I'm so encouraged by all the fantastic work that's being done across the country. And I would just say, for all that great work, publish it.
Thanks so much for those comments. And that brings us to the end of today's session. I'd like to thank Aaron, Cindy, Rupi, and Dan and Arlene for the insights they shared with us today. Thanks to everyone who joined the session. And I would just in closing say, this topic has been one that particularly to me highlights CADTH's new strategic plan about shaping future-ready health systems, and where we started off, which is unleashing the value of technology across the life cycle. And we've heard about remote monitoring across various cycles. So look forward to catching up on this in the future. Thanks, everyone. And if you want more information, please send an email to requests@cadth.ca. Take care and have a great afternoon.